And today we're going to be tackling the first of our 6-part series where we're really going to be focusing on the ECG and how we interpret the ECG. So this is kind of part of our fundamentals series where we really focus on some of these kind of basic clinical skills and will help you build in clinical practice. So in this part of this first series, we're really going to be looking at rate, rhythm and access. And through each of the lectures, we're going to build on more and more parts of the ECG, culminating in the final lecture where we're going to do lots of practice. Okay. Today we're going to be looking at a bit of electrophysiology, some of the basic components to help us interpret, and then we're going to start practicing through these different elements of the ECG. As always, this will take about an hour in time, maybe an hour and 5 minutes. There'll be time for questions at the end. If you have any questions throughout, just put them in the chat on the website if you're watching on app.pulsenotes or in the Zoom chat, and then we have to field those. There's a few breaks where we can answer some questions throughout, and there'll be a little bit of time at the end as well. Okay. So without further ado, let's get started. So the ECG, or EKG, depending on where you are, stands for the electrocardiogram. And essentially, the ECG is a visual recording of the heart's electrical activity. So a 12-lead ECG, which is the kind of standard ECG that we read and interpret, records the electrical activity of the heart from 10 electrodes. Now, we often refer to these electrodes as the leads. So it detects depolarization and repolarization of the heart. And we're going to come on to what exactly that means and what that's measuring in due course. So importantly, the ECG, all it's doing is offering multiple views of the heart through a combination of signals. Okay, so it's the single electrical activity running through the heart, but we're just viewing it from the left side, we're viewing it from the right, we're viewing it from underneath, we're viewing it from the top. We're just looking at loads of different positions of what's happening with that electrical activity. So to understand the initial bits of the ECG and why we're getting these spikes that are going upwards and some going downwards and the different waveforms, we need to understand a little bit about the heart and the electrophysiology. So conduction is dependent on pacemaker cells, which are formed into key anatomical structures. So it's composed, so the heart is composed of contractile cells and autorhythmic cells. And these autorhythmic cells are often termed pacemaker cells, so the terms are synonymous. So pacemaker cells make up around 1% of cardiac tissue. So the majority of the heart is composed of contractile cells, which are important for actual contraction of the heart and ejection of blood from the ventricles or from the atria. So a small proportion of these pacemaker cells, and these are the ones which are involved in initiation of this electrical activity. So they're organized into key structures which can undergo spontaneous depolarization. So essentially, different parts of the heart, these pacemaker cells are grouped into different areas which undergo depolarization together, where depolarization essentially refers to the initiation of electrical activity, which then generates this wave of electrical activity through the heart to lead to contraction throughout. So these key areas of pacemaker cells, which are formed into key structures, are the sinoatrial node at the top within the atria. This is usually where we initiate electrical activity first. You then get this wave of depolarization. We said that depolarization is essentially electrical activity, and that passes down to the atrioventricular node, named because it sits borders between the atria and ventricles. From there, we then have the bundle of His near the septum or in the septum, and then that goes down 2 bundle branches and then down into the Purkinje fibers. And that is our conduction system, which is completely set up. And through this conduction system, we get a rapid, fast, and coordinated electrical activity to then go through into the contractile cells and depolarize, leading to contraction. So that's the kind of bread and butter of the conduction system. So one of the really important concepts I want us to get today is this idea of spontaneous depolarization and autorhythmicity, okay? So this is one of the really key slides. So of these pacemaker cells, which are organized into these key structures, we said the sinoatrial node, atrioventricular node, bundle, hyst, and the branches. So each of these structures has its own intrinsic rate of autorhythmicity. So this essentially refers to the rate of spontaneous depolarization. So we said that depolarization was essentially the way a cell initiates electrical activity. So its membrane potential goes from predominantly negative, we get an influx of ions, it depolarizes it, becoming positive, and then undergoes at the threshold potential complete depolarization, and it's activated. And then that spreads to adjacent cells and the wave of depolarization continues. So these pacemaker cells undergo spontaneous depolarization because they don't need a trigger to depolarize them. Just by themselves, they will continue slowly going to that threshold potential, initiate electrical activity, and then go back to the baseline, and slowly, and then initiate electrical activity and back to the baseline. So they don't need any trigger. And essentially, at different areas of our structure, they are set at different rates. So the sinoatrial node will undergo spontaneous depolarization at a rate between 60 and 100. So this is why this area within the heart initiates electrical activity first. The atrioventricular node has this rate of spontaneous depolarization between 40 and 60 beats per minute. And the ventricles have a rate between 20 and 40. So this is why in the hierarchy, the sinoatrial node would always initiate electrical activity first. If this fails for whatever reason, then the AVM will take over as the next, with the next highest rate of spontaneous depolarization. And if the SAN and the AVN fail, the ventricles or areas within the ventricles will then take over as the third highest rate of spontaneous depolarization. Okay, so to recap, pacemaker cells have their own set intrinsic rate of spontaneous depolarization, which allows them to undergo activation and initiate electrical activity at a certain rate. And it's this hierarchy which governs why the SAN fires first and why that's where electrical activity is initiated within the conduction system. So why is this so important? Because this is why we have our ECG set going from the SAN down to the ventricles. This will also become more important as we talk about things such as escape rhythms later on in our bradycardias and conduction parts of our ECG series. So this is a really core part of ECGs and electrical activity to remember. So let's look at depolarization a little bit quicker, because this will help us work out why we're getting these different spikes and different waveforms on the ECG. So depolarization essentially is the change in charge between the inside and outside of cells, leading to initiation of electrical activity. So the passage of electrical current sequentially through the heart occurs when we have a wave of depolarization. And cells change from a resting polarized state to a depolarized state via an influx of sodium. So if we look on the diagram on the left, we have cardiomyocytes. On the outside, we have positively charged. And on the inside, the cell in the membrane, we have a negative charge in this resting polarized state. If we have it undergoes spontaneous depolarization, or there's a trigger, what happens is then, due to the influx of sodium, we get a depolarization of the cell, leading to more positive on the inside. And this then spreads across the cell, and we get complete depolarization. And that spreads throughout the whole of the heart, and we're depolarized. Once we've undergone our depolarization with this change in charge, we then need to reset the cells in preparation for the next wave of depolarization, and this forms repolarization. So again, repolarization like depolarization, is essentially the charge difference between the inside and the outside of cells. And in repolarization, we restore it to its resting polarized state. So due to closing of sodium channels and opening of potassium channels, there is restoration of the resting membrane potential. Okay. So all the ECG essentially is doing, it is assessing these depolarization waves, and it's assessing these repolarization waves. And that's what we're seeing on the ECG. The different spikes, the different waveforms are essentially reflective of the depolarization waves and the repolarization waves. And one of the really founding concepts from repolarization, depolarization, is the different deflections. And if you can understand this concept, it will help you really understand all of ECGs. So here we have two ECG waveforms, okay? So here we have two kind of QRS complexes. On the left, we have a positive deflection. So if we take the baseline, so it's the baseline, it goes up, down, and back to the baseline. So that baseline is the isoelectric line. When we have an up spike, that is what we call a positive deflection. On the right side, if we have the down spike going downwards, is a negative deflection. So if it goes down below the isoelectric line, it's a negative deflection. If it goes above the isoelectric line, it's a positive deflection. And what's really important is if the wave of depolarization is moving towards a positive lead, and we said the lead is one of the electrodes that we place for the ECG, then you'll get an upward deflection. If you have a wave of depolarization moving away from a positive lead, you will get a negative deflection. Okay, so moving towards a lead, positive deflection, moving away from a lead, negative deflection. And then one of the critical things is this process is reversed for repolarization. Okay, so this is why on an ECG we're getting these up spikes and these down spikes, because all it is it's our leads that are monitoring the wave of depolarization coming towards them or moving away from them. So this is the kind of basic principle why we're getting all these spikes on the ECG. So the actual ECG is created by attaching a number of electrodes or leads to different areas of the skin, okay? So on the right side, we can see a diagram, we can see a gentleman with all the lead locations, okay? So we have 4 limb leads. We have the right arm, the left arm, the left leg, and the right leg. And that's usually remembered by the mnemonic from right arm going round as ride your green bike. So R for red, Y for yellow, green for green, and black for bike. And then we have the locations of the chest leads going across the chest, okay? Generally kind of 4th intercostal space on the right side for the first lead, 4th intercostal space on the left side adjacent to the sternum, and then they're kind of going round in the corner at different set locations, okay? And this kind of is the principle for forming a 12-lead ECG. And remember, it's 10 leads, but we then get 12 views. And that's because the additional views come from the change or the difference between the limb leads, or several of the limb leads creates these other views. Okay, so we have the 6 views from looking at the chest leads, and then we get 6 views from different formulations of the limb leads. And this is what we get. So we get an ECG looking like this. So we have, in total, we have 12 different views, okay, across the top, and we'll come on to the chest leads and the limb leads in a second. And then right along the bottom, we have this additional, which is just a rhythm strip. It's just picking one of the leads, in this case, it's picking lead 2, and it's showing it for a long period of time. So we can really have a look at the rhythm along the bottom. So let's look at more closely at the limb leads and the chest leads. But just before we do, this is the basic calibration of an ECG. So these are some really important things to remember. So when we're looking at an ECG, we can think about the speed, the calibration, and the size. And the reason why this is important is because all ECGs are standardized so that we can interpret them wherever we are in the world, whichever hospital we're in. It's all completely standardized. So if I interpret it in one way, it will be the same as someone else interprets it in another location. Okay. So with the speed, important thing to remember is the small squares on an ECG are 1 millimeter. And then the large squares, which are a combination of 5 small squares together, or 5 by 5 square, are 5 millimeters. And then the ECG runs at 25 millimeters per second. Okay, so that means that you'll go through 5 large squares for every second. With the calibration, generally 1 centimeter or 10 millimeters is equivalent to 1 millivolts of energy. And then with the size, so for each of these small squares, it's equivalent to 1 millimeter, as we said, or 0.04 seconds, or 40 milliseconds. And then with the large squares, which is the 5 small squares together, we said that's 5 millimeters, or 0.2 seconds. So these are some basic calibrations to remember. So when we look at the leads, so there are 6 standard limb leads, and these are recorded from electrodes that attach to the leads. So we said that with the limb leads, we have the right arm, left leg, and right leg. And then that creates 6 electrical views of the heart. So we can group the limb leads into 3. We have the inferior limb leads, the lateral limb leads, and the right arm limb lead. So the inferior limb leads gives us 2, 3, and AVF, and that looks at the inferior surface of the heart. The lateral limb leads are 1 and AVL, and they look at the lateral surface of the heart. And then we have the right arm gives us AVR, which looks at the right atrium, and this should always be negative. And that, when I'm saying negative, I mean a negative deflection. I mean predominantly the waveforms are going downwards below the isoelectric line. And this is what we get. So essentially, it's one wave of depolarization through the heart, but we're looking at the heart and that wave in multiple different views. And these are our 6 limb leads, which are just looking at that one electrical wave depolarization in various ways. So we can see going round from left to right, AVR predominantly negative because it goes below the isoelectric line. Then we then have 3 AVF, 2, 1 AVL, and we can see that it's all different shapes of that normal ECG or normal waveform of ECG. And that's because there are different positions relative to the average wave depolarization going through the heart. So they're going to look slightly different. And on the ECG, this is our limb leads on the left. Okay, so we have 1, 2, 3, and AVR, AVL, and AVF. Okay, so our limb leads all stacked on the left-hand side, and we can look at those. So then there are 6 standard chest leads, which are recorded from electrodes attached to the chest. And like the limb leads, so there are 6 chest leads. And these can be divided into septal leads, anterior leads, and lateral leads. So the septal leads are V1 and V2, and these look at the right ventricle and the ventricular septum. We have the anterior chest leads, V3 and V4, which look at the left ventricular anterior wall. And then we have the lateral leads, V5 and V6, which look at the left ventricular anterior and lateral walls. And we can look at these in closer detail. So we have our 6 chest leads across the chest wall. And then again, it just gives us a different representation of that electrical activity because we're viewing the electrical activity going through the heart from different positions. So if you compare V1 to V6, they look like different complexes because we're viewing that depolarization wave through the heart in different positions. And what you can see is that V1, V2, and V3 are all predominantly negative. By that, the deflection is predominantly going downwards below the isoelectric line. whereas V4, V5, and V6 are predominantly positive because the deflection is going upwards above the isoelectric line. And that's because the wave of depolarization is generally going towards V4, V5, and V6, and going away from V1, V2, and V3. So if the average wave of depolarization is going towards, we get positive deflection. If the average wave is going away, we get a negative deflection. So if you think that the wave of depolarization is starting the top bit of the heart, it's initially going kind of towards V1, but as it passes that lead, it's then definitely going away to V4, 5, and 6, which is why in V1 we have this initial upstroke that's kind of going towards, and then we have this big downstroke because it's then definitely going away. So all this is viewing on these different areas are whether relative to the wave of depolarization, is it going away or is it going towards the lead? And on the ECG, on our 12-lead ECG, we can see on the right side, we have our 6 chest leads. So then that makes up our whole ECG. The left, we have the limb leads. We then have 6 chest leads, V1, V2, V3, V4, V5, and V6. And then along the bottom, we get a nice rhythm strip, which allows us to look at the one lead in more detail over a longer period of time to help us work out the rhythm. Okay. So looking at waveforms, so this is the different components of the ECG, the upward deflections or the negative deflections. So the basic ECG strip is made up of a baseline, so that isoelectric line, with deflections caused by movement of electrical impulses. And these deflections, as we said, are either going upwards, so they're positive, or they're going downwards because they're negative. And the deflections that make up a normal ECG are termed waves, and they're assigned arbitrary letters. So we could just look at an ECG and say, oh, there's a positive deflection there, negative deflection there, positive there. But actually what makes it easier is we say, right, rather than saying that and saying all these different deflections up and down, we're going to say this is the P wave. This is the QRS complex. This is different arbitrary letters to help us communicate what the ECG means much easier. So let's look at the waveform. So starting with the P wave. So this is the first component of the typical standard waveform on an ECG. So the P wave represents atrial depolarization. Okay, so depolarization, think about it as electrical activity being initiated. So it's the small wave at the start of the ECG waveform, and it represents normal electrical activity from the sinoatrial node. And essentially what you're getting is as that's going up, you're getting a slow depolarization from the sinoatrial node throughout the atria to the atrioventricular node. So the absence of P waves means that the SAN is not firing properly. Or if we get an abnormal looking P wave, it's occurring somewhere else within the atria. So for a normal appearing P wave, we need nice coordinated electrical activity starting in the SAN and traveling down to the AVN. We then have the QRS complex. So the QRS complex represents ventricular depolarization. And the reason it's much bigger than the P wave is because the deflection also depends on the mass undergoing electrical activity. So the ventricles are much bigger, heavily muscular structures. So therefore their magnitude of electrical activity is much greater than the atria, which is why the QRS complex appears much bigger. So the QRS complex should be less than 120 milliseconds, so less than 3 small squares. And if the first deflection is down, so if it goes down first, negative below the isoelectric line, then we say there's a Q wave. If the first deflection is up, there's no initial negative deflection, then it's just an R wave. So the standard QRS complex, we go down first for a Q wave, up to our R wave, and then down to the S wave. If it goes initially straight up and then down, that is just an RS wave, and we don't have a Q wave. And some leads, you will see, will just have an R and an S wave and won't have a Q wave. And the reason why that is is that Q waves develop due to the initial septal depolarization. So within the ventricle structure, the septum depolarizes first. And this occurs in a left to right direction. Therefore, it goes towards the septal leads, V1 to V2, but away from the lateral leads. So remember, we said that with depolarization, if it goes towards the lead, we get an upwards deflection. If we get away from a lead, it's a negative deflection. So in V1, with our left to right depolarization going from left to right, it goes towards V1. So initially that's an upward deflection, so we get an R wave over a Q wave. Whereas in V6, from left to right, it's going away from that lead 6, which is right round in the axilla. So therefore we get an initial negative deflection. Okay. So that's really important. So that's why we're developing those Q waves, is because initially we're getting septal depolarization first. And then the rest of the QRS complex is then made up depending on whether it's going towards or away from the leads. The T wave then represents ventricular repolarization. So it's normally upright and it precedes the QRS complex. So abnormal T waves can be part of normal variation depending on when they are. So they can be inverted in AVR, and they may be inverted depending on the patient in leads 3, AVF, AVL, and V1 to V2. So there's lots of ethnic diversity with T waves as well. If they're inverted, there will be a negative deflection downwards. Now, the reason why the T wave is up, because the upward or negative deflection sort of rule that we talked about is opposite for repolarization. So if repolarization is moving away from a lead, then it's an upward deflection. If repolarization is moving towards a lead, then it's a negative deflection. So it's the complete opposite for depolarization. We then have different other sort of components of ECG that are important to know about. So we have the PR interval going from the P to the R wave, or the start of the Q. So it represents a delay in conduction at the atrioventricular node. So the PR interval is the time taken for depolarization to pass from the sinoatrial node to the ventricular muscle. And it's normally around 120 to 200 milliseconds, so 3 to 5 small squares. And the important part of the atrioventricular node is to essentially pause electrical conduction, allow time for the atria to contract and empty blood into the ventricles, and then continue electrical activity to then allow ventricular contraction, passing that blood out into the systemic or pulmonary circulations. So it's a physiological pause, which is there to help filling of the ventricles before contraction. We then have the ST segment, which essentially under normal circumstances remains on that isoelectric line. So essentially the baseline on the ECG. And it runs between the S wave and the start of the T wave. So the ST segment is situated between the QRS and the T wave, and it should be flat. So elevation or depression of the ST segment is pathological and usually a sign of ischemia amongst a number of other conditions. And we'll cover this a lot in our waveforms part of the ECG series. Then finally, we have the QT interval, which is the time taken for ventricular depolarization and repolarization in total. So it's the time between the start of the Q wave and end of the T wave. So it varies with heart rate, and the normal QT interval is around 350 to 440 milliseconds in men, and 350 to 460 milliseconds in women. So it's slightly different depending on sex. And one important thing is you may hear something called the corrected QT interval, which is essentially estimating the QT based on the standard heart rate. And there are loads of formulas which are used to calculate the corrected QT interval. And one of these formulas is the Bassett, which essentially is the QTC, the corrected QTC, is the QT interval divided by the square root of the R to R interval. So that being the difference or the length between two R complexes. We've talked about the basic electrophysiology. We've talked about some of the waveforms. We're now going to focus on rates, rhythm, and have a look at access. So this is our ECG, our 12 ECGs. So we looked at the limb leads, 1, 2, 3, AVR, AVL, AVF, and we looked at the chest leads, V1, V2, V3, V4, V5, and V6. We know there's a rhythm strip along the bottom, and we know that the waveforms, we can see P waves, the QRS complex, remembering that in different components, we may not have a Q wave because, for example, in V1, we can see here, it initially goes up, then down, because we have that initial septal depolarization going from left to right, so towards this V1 and then away from it, okay? Whereas in other leads, such as V5, V6, we have a very small Q wave and then goes up, okay? So it's all relation to where the depolarization is occurring and where in relation to the leads. We can see those QRS complexes and we can see the T waves as well, okay? So we're now going to look at rate. So just based on this ECG, what is the rate in this ECG? So think about yourself now, have a think how you may calculate it if you know, and then we will give you two methods in which you can calculate the rate easily on ECGs. So take a moment now to see whether you can work out roughly what rate it is. Let's talk about how we then work out the rate. So rate is essentially the number of times the heart beats per minute, and it can be normal, fast, so greater than 100 beats per minute, or slow, less than 60 beats per minute. And remember, this is generally referring to the ventricular rate, and under normal circumstances, the ventricular rate will equal the atrial rate, okay? However, if there's a problem between conduction going from the atria to the ventricles, you may have separate ventricular and atrial rates, but we'll come on to that in later lectures. So for now, for a normal ECG, for normal rhythm, the ventricular rate is the number of times the heartbeats per minute, which equals the atrial rate. And when we're calculating rate, there are two methods. There's the division method and the multiplication method. So with the division method, you measure the number of large squares between two R to R complexes. You then divide 300 by this number, and you can do this for all regular rhythms. With the multiplication methods, essentially you count the number of QRS complexes within 30 large squares, which is equivalent to 6 seconds. And then you multiply this number by 10. So 6 seconds times 10 is 60 seconds, number of beats per minute. And you can use this for regular or irregular rhythms. So let's look at some examples of those. So in that same ECG, essentially, between two R to R complexes, so we take the R complex on the rhythm strip of one QRS complex, we then look at the distance between the next adjacent R complex of a QRS complex. And here it's roughly around 4.5. So 300 divided by 4.5 is 67 beats per minute. You know, you could say roughly, we said that we've measured it about 4.5. If you measured it at 4, that would be around 75 beats per minute. And that's exactly what you're doing. And you can do this for any regular rhythm. The multiplication method is you're taking 30 large squares. How many of these QRS complexes occur within those 30 large squares? So here we've measured out 30. We then counted the QRS complexes, and that's equivalent to 7. We've done 7 times 10, so it's 70 beats per minute, okay? And this is useful for both irregular rhythms and regular. Because in an irregular rhythm, how do you know which R to R complex to use? Because they'll be different. So irregular or irregular, the multiplication method. If it's regular, you can use the division method. And either one is completely fine to use. So the next question is, that's rate. So whenever we take an ECG, the first thing we do is work out whether the ECG is all the calibrations are right, and you can normally assume they are. And then we work out the rate using the multiplication or division method. The next thing we do is work out the rhythm of the ECG. So in this ECG, you may know, you may not know, but have a go at what do you think is the general rhythm of this ECG? So most people are saying it's normal sinus rhythm. And that'll be absolutely right. So for those who don't know it's normal sinus rhythm, let's work through why and what that means. So rhythm refers to the part of the heart that's coordinating electrical activity. So when we think about rhythm, we're saying where in the heart is electrical activity initiating and being coordinated from? So under normal circumstances, the sinoatrial node, or the SEN, initiates electrical activity. So normal activity from the SEN to the AVN leads to P waves with normal morphology. And therefore, sinus rhythm is generally referring to the activities being initiated in the sinoatrial node. Then we need to make sure that there's normal conduction to the ventricles. And if we have normal conduction initiated from the SEN, normal conduction to the ventricles, you're essentially getting sinus rhythm. So let's look at that in an example. So normal sinus rhythm is a very particular term. And essentially what it's referring to is if we take this rhythm strip, we can see there's P waves, there's QRS complexes for every P wave, there's normal T waves, the PR interval we can say is normal. So actually the defining feature of the normal sinus rhythm is it's initiated in the sinoatrial node, so there's a P wave. There's normal atrioventricular conduction, so there's a 1-to-1 ratio. So every P wave is followed by a QRS complex, the 1-to-1 ratio. We have a normal PR interval, and we have a normal heart rate, so 60 to 100 beats per minute. So these are the defining features of normal sinus rhythm. So one thing really important to take home is you want normal electrical activity being initiated in the sinoatrial node, and you have that 1-to-1 conduction showing normal atrioventricular conduction, 1 P wave to 1 QRS complex. So there are lots of things we want to work out as part of rhythm assessment to work out whether there is normal sinus rhythm. So one of the things we want to work out is there an abnormally fast or an abnormally slow rhythm? So we term abnormal heart rhythms arrhythmias, and they can broadly be divided into bradycardias, so slow rhythms, or tachycardias, so fast rhythms. So if the rhythm is sinus but fast, we refer to this as sinus tachycardia. If it's sinus but slow, we refer to this as sinus bradycardia. So let's look at those in an example. So with sinus bradycardia, we can see that it's slightly slower, but the defining features, again, it's still initiated in the sinoatrial node because there's P waves. There's still normal AV conduction because there's 1 P wave to 1 QRS complexes in a 1-to-1 conduction. There's a normal PR interval, so 120 to 200 milliseconds, but the heart rate is slow. So this is an example of sinus bradycardia. In sinus tachycardia, we can see it's much faster, but again, initiated in the sinoatrial node with P waves. There's normal AV conduction with 1-to-1 ratio. There's a normal PR interval, but it's just fast. So this is an example of sinus tachycardia. And there are many different causes of abnormally slow or abnormally fast rhythms, okay? And we'll be covering these in 2 of our later ECG parts, dedicated solely to bradyarrhythmias and to tachyarrhythmias. So some example abnormal rhythms that you may see are in bradycardias. You may have sinus bradycardia, sinus pauses, escape rhythms, and heart blocks. And with tachyarrhythmias, you may have sinus tachycardia, supraventricular tachycardias, ventricular tachycardias, atrial fibrillation, atrial flutter. So these are all common abnormal rhythms that can be fast or slow. And we're going to cover all of these at a later date. So as part of our rhythm assessment, we said, is there evidence of sinus rhythm? Is it fast? Is it slow? We then need to decide, is it regular or irregular? So whether a rhythm is regular depends on the distance between adjacent QRS complexes, particularly adjacent R waves of those QRS complexes. If the RR interval is constant, we can assume the rhythm is regular. If the RR interval differs across beats, we can say the rhythm is irregular. So here's an example. At the top, we have a regular rhythm because that RR interval is constant. We have a regular rhythm. In the bottom one, we have an irregular rhythm because the RR interval differs between beats. Now, with irregular rhythms, they can then also be regularly irregular. So that differential in the RR interval is occurring at regular intervals, or it can be irregularly irregular. So it's complete randomness of the R to R intervals, okay? But just remember in your head, R to R intervals is used to determine whether a rhythm is regular or irregular. So let's have a look at this ECG. Again, standard 12-lead ECG. On the left, we have our 6 limb leads, 1, 2, 3, AVR, AVL, AVF. On the right, we have our 6 chest leads, V1 going through to V6. And then we have a ribbon strip along the bottom, allowing us to look at the rhythm of the heart over a prolonged period of time. And it usually chooses kind of 2 or V1. So in this ECG, is the rhythm regular or irregular?
Okay, so most people are saying it is irregular. Some people are saying it's regularly irregular, and some people are saying it's irregularly irregular.
So, absolutely. So this is an irregular rhythm. Because if we look at the start on the left side of the ECG in the rhythm strip, so when we're trying to think about rhythm, we use rhythm strip at the bottom, we have a long read to look what's going on. If we look at that left side, you could say, oh, it looks like it may be regular initially. But then as you walk your eyes across that ECG, you can see there's these abnormal complexes. The R to R interval is then very random, particularly towards the right-hand side. So this is an irregular rhythm. Determining whether something is irregularly irregular or regularly irregular is actually very difficult. And here, I would say probably it's more likely to be irregularly irregular, because these random beats we'll come into later are actually ectopics, which complicate the situation. But the principle here is you can recognize the R to R interval is different, so therefore it's an irregular rhythm. And as part of our hierarchy of working out an ECG, we work out rate, then we work out rhythm. With rhythm, we're saying, is there sinus? Is it regular? Is it irregular? Is it fast? Is it slow? So with rhythms, there are certain conditions that usually cause a regular rhythm, and there are certain conditions cause an irregular rhythm. So having a kind of knowledge of these is very useful. So when you see an irregular rhythm, you can immediately go to your list differentials being, is it one of these? So regular rhythms, so normal sinus rhythm, sinus tachycardia, sinus bradycardia, typical kind of SVTs and atrial flutter can all cause regular rhythms of a fast or slow nature. So typical irregular rhythms are things such as sinus arrhythmia, ectopic beats, these extra beats we'll talk about, pauses and blocks, atrial fibrillation, and atrial flutter with variable blocks. So we will be covering all of these in later lectures, but this is an example where you can have lots of regular rhythms or irregular rhythms. So the final thing to think about with rhythm before we look at ectopics is working out whether the rhythm is originating in the atria or whether the rhythm is originating in the ventricles. So when a rhythm originates from above the ventricles in the atria, we term it a supraventricular rhythm, a rhythm above the ventricles. So a supraventricular rhythm generally refers to an ectopic rhythm originating from an abnormal position. So technically, sinus rhythm is a supraventricular rhythm because it's occurring above the ventricles in the atria. However, we generally reserve the term supraventricular for this ectopic abnormal rhythm that's originating away from the sinoatrial node. So if the AVN and His bundle are intact and they're conducting normally, regardless of where the supraventricular rhythm is originating, we have normal conduction through the bundle of His, through the bundle branches, and through the Purkinje fibers. So ventricular conduction is normal. And remember, ventricular conduction is essentially a reflective of the QRS complex. So regardless of where that supraventricular rhythm is, if we have a normal QRS complex, then we know that it's a supraventricular rhythm. So therefore, the width of the QRS complex is used to determine these rhythms. So with a supraventricular rhythm, we have a narrow QRS complex. Largely, there are some caveats to this rule, but that's because it goes through the conduction system normally. You have that normal narrow QRS complex, less than 120 milliseconds, less than 3 small squares. It's a supraventricular rhythm. The one caveat to this is if we have a bundle branch block, which we will look in the next lecture on conduction. When the rhythm originates from within the ventricles, it's termed a ventricular rhythm. So a ventricular rhythm may originate from anywhere within the ventricles. The ectopic electrical activity does not enter that normal conduction system through the bundle of His, through the bundle of branches, and through the Purkinje fibers. It slowly conducts throughout the whole of the ventricles from abnormal condition. So because it slowly depolarizes the whole of the myocardium, not in the normal conduction system, we get a broad abnormal QRS complex. So we get this broad abnormal. So if we see a beat or a structure with a very broad QRS like this, we can assume in the absence of a bundle branch block that it is originating from within the ventricle system, leading to this broad QRS, so we have an abnormal ventricular rhythm. So remember, narrow complexes are generally originating from the atria, broad complexes generally originating from the ventricles, with the one caveat being bundle branch blocks, which we will talk about in the next lecture. So the final thing to think about a rhythm is if part of the heart depolarizes earlier than expected, we term this beat an ectopic. So remember, with our hierarchy of spontaneous depolarization, the sinoatrial node always undergoes depolarization first. If that fails, the atrioventricular node will depolarize first. And if that fails, we then have the ventricular system, which depolarizes. So the SAN activates the AVM, which activates the ventricles. If one of those depolarizes abnormally earlier, we get an extra beat. We get this kind of ectopic beat, and we can see that on the ECG. So an ectopic beat is also known as an extrasystole, and they're very common. We see them in normal individuals. So extra beats may originate from within the atria, away from the sinoatrial node, around the atrioventricular node, or within the ventricles. So atrial and nodal ectopics, nodal being around the atrioventricular node, are usually grouped together as supraventricular ectopics, and then we have our ventricular ectopics. So let's look at these. So with an atrial ectopic, somewhere an extra beat occurring away from the sinoatrial node, we have 3 defining features. There's an abnormal P wave because it's not occurring within the sinoatrial node. There's a narrow QRS complex because despite it occurring somewhere else within the atria, it still then subsequently goes through the normal conduction system. And there's a compensatory pause due to the resetting. So if we look at this rhythm here, we have this ectopic beat, which has occurred prematurely early, so an extra beat. We have a slightly abnormal P wave. You can see it looks different to the morphology of the other waves. And then we have this compensatory pause. So this is an example of an atrial ectopic beat. With a nodal ectopic, because it's occurring within the atrioventricular node, we have no P wave because there's no depolarization going through the atria. It goes straight from the atrioventricular node into the QRS complex. Or it may be hidden because there may be some retrograde conduction, but because the QRS complex is more dominant depolarization mass, it's then hidden within that complex. There's a narrow QRS because it goes through the normal ventricular conduction system. And again, there's a compensatory pause. So we can see it here. We've got our ectopic occurring abnormally early. There's no P wave that's occurring within the node. And then we have this compensatory pause. And then finally, with a ventricular ectopic, we have an absent P wave because a P wave is reflective of sinoatrial node atrial activity going through the atria. So in this case, it's occurring in the ventricles. We get no P wave. We get a broad abnormal QRS because we're getting a slow wave of depolarisation throughout the whole of the heart, and there's no compensatory pause. So we can see here, we can see this abnormal ectopic beat. We're occurring with this broad QRS complex, and then we have no compensatory pause, and we go straight back into our normal rhythm initiating in the sinoatrial nodes. So on this ECG, what do you think is the rate and the rhythm of this ECG? And can you see any extra beats anywhere?
This is actually a really hard one, isn't it, Ben?
Yeah.
You have to have a keen eye, but yeah, use the basic principles, work at your rate, work at your rhythm, and then if you can spot anything else abnormal, let us know. There's silence from the audience, Ben. Bearing in mind this is 600 odd people.
Always takes a bit of time to work out, sit down, to concentrate.
So some people are saying this is normal sinus rhythm with estimates of the rate of 75 or 8 or 78. Some people are saying it's irregular. Some people are saying there are ectopics in chest leads 4, 5, 6. Yeah, I think you've flummoxed everyone, Ben.
Okay, so the rate, I'd say, if you use the division method, it's around kind of 4.5 squares. So it's going to be around 67, 75 beats per minute. Okay. Then generally, if you look across all of the complexes, generally everything, there's a P wave for most complexes. Every P wave is followed by a QRS complex. So there's one-to-one conduction. The PR interval is normal because it's between kind of 3 and 5 small squares. So this all kind of satisfying normal sinus rhythm. Now there's one additional beat, the third from the end, which comes slightly early. It makes it look like the rhythm is irregular. And if you trace it up, so one of the important things is look at the rhythm strip. If you trace that complex up into V6, V5, and V4, that's the same timing for that beat across all of them. And if you look very closely or subtly, the P wave here in the rhythm strip is different to the P waves across the rest of the complexes. And because it occurs slightly early, there's then this compensatory pause. So this is actually normal sinus rhythm, or it's sinus rhythm with an atrial ectopic because there's an abnormal P wave occurring early and then a compensatory pause. And this just shows you this can be very normal ECGs that otherwise appear normal. And this is why it's actually a regular rhythm, but we have this extra beat. So technically, this is sinus rhythm, not normal sinus, because there's an abnormality that we found in the atrial ectopic. Okay. So on this ECG, so we've seen this one previously, it was an irregular rhythm. So can you see any abnormal complexes which might represent something that we've just been talking about?
So people are saying there are ventricular ectopics, which sounds promising, in AVL, AVF. And they can identify it because there's a widened QRS.
Perfect. So this is showing some key things here. So the background ECG is atrial fibrillation, but we're not going to be talking that today. Here, the main thing is we can see there's these random extra beats that are occurring. They have a broad QRS complex. And just remember, if you look at the rhythm strip along the bottom, and then we get to this first abnormal broad beat, if you look up into AVR, AVR, and AVF, all that's showing you is at that point in time to that beat, that is what that abnormal complex looks like and the different lead positions. So that's what it looks like in AVR. It's what it looks like in AVL. It's what it looks like in AVF. So it's the same beat being looked at from different positions at that point in time. And we can see that they occur in 3 positions. So these are ventricular ectopics, okay? Because they are broad, they're extra beats, and it goes back to the underlying rhythm afterwards. So we've looked at electrophysiology, we've looked at what forms ECG, the different leads, and then we've looked at how we calculate rate with the multiplication division method, and then we've looked at rhythm, how we look at the defining features of normal sinus rhythm. We're looking for that normal one-to-one conduction with the atrioventricular, and then we looked at things such as fast or slow, regular, irregular, and then we also looked at ectopic. So now we're going to look at access. So cardiac access refers to the net effect of all the generated action potentials. So leads AVR and 2 look at the heart from opposite directions. So one looks up here and then looks down across the heart. So the normal wave of depolarization passes from 11 o'clock in AVR to 5 o'clock in lead 2. So AVR has a predominant downward deflection because it's moving from AVR down across the heart. And lead 2 has a predominant upward deflection because the wave of depolarization is passing to lead 2. So remember, that's go back to our principles. If it's going towards a lead, it's an upward deflection. If it's going away from a lead, it's a negative deflection. So this is showing that here. So the average spread of depolarization is part of this arrow, okay? So depolarization will be occurring in lots of different directions, but we have an overarching average wave of depolarization which is detected, which has the highest rate of electrical activity. So we can see that AVR is predominantly negative because it's passing away, and lead 2 is predominantly positive because it's going towards lead 2. And we can see that as a dominant R wave here, so a very big up spike in the QRS complex, and we can see a dominant S wave in AVR, so a predominant negative spike in AVR. And this is the principle of access. What is that average wave depolarization? Which direction is it going in? So the normal cardiac access can be measured in degrees, and it runs from negative 30 degrees to positive 90. So if you look at the diagram, we have AVR going off on the left, and then we have all of these limb leads around on the outside. So the normal access is between AVL to AVF. So if the average wave of depolarization goes in any of these directions within this green area, that would be normal access. So deviation in access, going left, deviating left, or deviating right, may indicate underlying conduction disease, so disease to the pacemaker cells and conduction system, or it may indicate acute cardiac pathology. So if conduction is delayed in one direction, the axis may be deviated. So it can be deviated to the right, or it can be deviated to the left. If one side exerts a greater electrical activity, so let's say we have a really big, bulky right ventricle, then we may get deviation because a greater amount of electrical activity is going towards the right ventricle. So in practice, measurement of the cardiac axis in degrees is not clinically very useful, okay? And there's a much simpler method to work out axis that's really easy that we're going to work out now. So when the average wave of depolarization is shifted to the left, it goes beyond negative 30, so beyond AVL. We refer to this as left axis deviation, okay? And classic things of left axis deviation are things such as left ventricular hypertrophy, left bundle branch block, or left anterior fascicular block. And we're going to be looking at all of those in the next lecture on conduction. So when the average wave of depolarization is shifted right beyond plus 90, we term this right axis deviation. And this may be anything that's affecting the right side of the heart. So chronic pulmonary disease, right ventricular hypertrophy, pulmonary embolism, lots of these problems. And again, we'll be covering all of this in our conduction lecture. So now, how do we work out if it's deviated to the right beyond plus 90, or how do we work out if it's deviated left beyond negative 30? So the answer lies in leads 1, 2, and 3. So in practice, the cardiac axis is easily derived from assessment of the limb leads 1, 2, and 3. So what we do is we look at the net deflection of limb leads 1, 2, and 3. So this essentially means whether a lead is predominantly negative or is it predominantly positive. And we can use whether leads 1, 2, and 3 are predominantly negative or positive to then work out the axis. So under normal circumstances, lead 2 should show the greatest upward deflection because that's essentially where the wave of depolarization is heading towards. And this is the table that we can use to help us work it out. So on the left-hand side, we've got our 3 leads, 1, 2, and 3. And then with each column, we've got what would happen in normal axis, what would happen in left axis, and what would happen in right axis. So in normal axis, if they're all positive, or if lead 1 is positive, 2 is positive, and lead 3 can be positive or negative, that is equal to normal axis. And when we say positive, we mean predominantly upward deflection. So the R wave is greater than the S wave. And we can see that there in all the small diagrams. In left axis deviation, lead 1 is positive, but lead 2 and 3 are negative. So we can see in lead 1 is predominantly positive going upwards, whereas in leads 2 and 3 is predominantly negative. So in lead 2, there is a little bit up in an R wave, but there's a predominant S wave, which is much greater than the R wave. So the overall net deflection of this lead is negative. And then in right axis deviation, you can have, if lead 1 is negative, lead 2 can be negative or positive. But then if lead 3 is the most positive lead, so the net deflection going upwards is the highest, this is right axis deviation, okay? So whenever you look at an ECG, once you've worked out rate, once you've looked at the rhythm, you then look at the axis, and then using these 3 leads in this table, you can work out whether it's left, right, or normal. So let's put that into practice. So here we've got a 12-lead ECG. What is the cardiac axis on this ECG? So using those principles, so immediately your eyes should go shift straight away to leads 1, 2, and 3, because that's where the money is. That's where we're going to work out the axis. And then we want to work out whether the average deflection of each of those leads, and using the 3 of them together, work out whether it's normal, left, or right.
Perfect. Some answers already. I think you'll be able to build in the table on the next slide, Ben. So maybe give them the table, and then for people who are a bit unsure, they'll be able to work it out.
Okay, here's the table.
So quite interesting, because once we put in the, so most at the start everyone was saying normal, and then we've put in the table and we've got a lot of left axis deviations. So do you want to tell us the answer, Ben?
So it's interesting. So why is everyone going for left axis deviation in the table, for the table?
Yeah, probably about 50-50 between normal and LAD. So maybe if you just talk through your working, Ben.
Okay, so in this example, looking at 1, 2, and 3. So if I look at lead 1 to start with, the QRS complex is predominantly positive. We can see there's a little Q wave, a really big R wave, and then back to the baseline. Okay, so it's predominantly positive. So that's a positive lead. We then look in lead 2 at the QRS complex. Again, it's predominantly a positive lead because we have an upward deflection. There's no real downward deflection. So this is predominantly a positive lead. Then in lead 3, we have a little R wave upwards, and then we have a deep S wave downwards, which is definitely bigger than the R wave. So this is predominantly a negative lead. So we have a positive lead 1, a positive lead 2, and a negative lead 3. So if we then use the table, we can see that it's going to be normal or left because lead 1 is positive. It's now definitely going to be normal axis because lead 2 is positive, because it's not, if it was left axis, lead 2 would have to be negative. So this is an example of normal axis.
Perfect. Shall we do the next one?
Okay. Then, so with this one, think about it again. What is the cardiac axis of this ECG? And then we're going to put the table up as well. So what's the axis here?
Good. So most people have gone for left then.
Okay. So yeah, so again, we go through it. We look at lead 1. Lead 1 has an R wave and a small S wave, but the R is much greater than the S. So this is predominantly a positive lead. In lead 2, we have a little R wave, and then we have a slightly bigger S wave. So we can see on this that actually it's predominantly a negative lead because the S wave is bigger than the R wave. And then in lead 3, it's predominantly a negative lead. We can definitely see that going downward with quite a significant amount. So we have a positive lead 1, negative lead 2, negative lead 3. So this is left axis deviation. If the R wave equals the S wave, then that's a kind of isoelectric lead. And the wave of depolarization is going perpendicular to that lead. And that can be a bit tricky to work out exactly where it was. So you'd never get that in an exam question, but it may be on the borderline between left axis and normal if that was occurring. Okay, so let's briefly summarize. Thanks for staying with us, guys. There's a lot to cover today, and then we'll take any questions at the end. So we've covered the first of our 6-part series today on ECGs, and today we're really focused on the rate, the rhythm, the axis, and some of the basic concepts. As we go through, we'll be covering more things such as conduction, looking at the waveforms, Brady and tachyarrhythmias, and then we'll be looking at practicing in making perfect. So here we looked at the basic ECG and how it's created by attaching a number of electrodes or leads to different areas of the skin. And we looked at the limb leads, we looked at the chest leads, and how that represents viewing the heart from different areas. We looked at the waveform of the ECG and how the ECG strip is made of baseline with deflections caused by electrical impulses. And these deflections are going up if they're going towards the leads, or going down, going away from the leads. And we said the repolarization is the opposite effect. We then looked at rate and rhythm, for how for every ECG we must work out the rate, and then we look at the rhythm, and how rhythm essentially refers to the control of electrical activity. We remember with rate, we said you can have the division or multiplication method, and then with rhythm, we look at what's controlling it, what are the waveforms like, what's the conduction between the atria and ventricles, and then we talked about whether it's fast or slow with some common bradyarrhythmias and some common tachyarrhythmias. And then finally, we looked at cardiac axis, how it refers to the net effect of all the generated action potentials going from -30 to +90, and how if it's deviated to the left, it's left axis deviation. If it's deviated to the right, it's right axis. And we showed you how you can work it out in practice easier by using leads 1, 2, and 3. So that concludes our lecture, our first part of our series. We love to get feedback from you guys on what you thought for today, how it went.